Another complicating factor to this is the fact that these drugs get metabolized in the body, and we oftentimes see the parent drug, let's say the patient's on hydrocodone, for example, and you're going to see hydromorphone and hydrocodone show up in the urine. Or a recent patient I had where the hydrocodone didn't show up, but the hydromorphone did. Now, hydromorphone, you all know, is dilaudid. So patient's taking a Vicodin, and now dilaudid shows up in the urine. Is that okay or not okay? It's a difficult situation to understand about the metabolites. And I'm going to go to Humam and ask him about how do you use the metabolites and how do you make sense of all this?
It's important when you start ordering urine drug screen to be able to identify that every drug has metabolite, and some of the metabolites are active metabolites and some of them are non-active metabolite. And in order for us to be able to make a clinical decision about the further treatment, we have to understand the metabolite. And let's take a few examples, that could identify the picture. If a patient on hydrocodone metabolite, it's active, which is hydromorphone. The patient urine drug screen will come back positive for hydromorphone. If the physician, the ordering physician, is not knowledgeable enough about that the patient is on hydrocodone, the test is positive hydromorphone, he would think that the patient is not taking the hydrocodone, would think the patient is taking dilaudid or hydromorphone, and then a conflict will happen. So expected results is to be hydromorphone. We'll talk about another drug. We'll say about, for example, when we talked about ingestion of medications, if the patient is taking illegal drugs of heroin. And this is where I'm going to try to make now clinical judgment, because the interpretation of a urine drug screen will help me manage the patient, not only screen test the patient. Meaning, if a patient has a long history of heroin abuse, he said he's been sober, he went treatment facilities, I should not start this patient on morphine for his pain control, because the metabolite could be mixed with heroin, as heroin metabolite is morphine. So in order for me to be able to separate any kind of misconception, I should avoid the drugs that metabolite make a confusion to my clinical picture in order for me not to start it.
So let me just make sure I understand. So the patient could be reusing their heroin. The only way you would know is because your urine test shows morphine. But if you're giving morphine, then you've lost that ability to find out that the patient's on heroin. Is that, am I understanding?
That is correct.
Okay.
This is where we have the options of using different drugs. If I am having a urine drug screen came back positive for oxymorphone, and I'm giving the patient hydromorphone, which means the patient is taking oxycodone. So definitely there's no metabolite interaction. So I have to know that the patient is using a different drug. Even though if I find hydromorphone positive and I find oxymorphone positive, so the patient is taking prescription drug not prescribed by me. So this is why it's extremely...
And that's a problem.
And that's a big problem.
Yeah.
So it is crucial and essential for us to understand the metabolite of any particular drug to help us guide the treatment. And now I'm talking about beyond the testing, I'm talking about also how to guide the treatment for the patient. So this is an added value of a urine drug screen beside finding illegal drugs and legal drugs and compliance. This is also tell us, really guide us of which drug to use to treat this patient. Soma, for example, has an active metabolite, so we have to be careful of also what to order and what to look for.
So I think this has been an excellent conversation. I just want to bring up some key points is when you get something you don't expect, have an idea, first of all, what you think you should see in the urine. If it's unexpected, corroborate that with your lab. Call them up and say, gee, could this be possible? Is there something wrong? Get the patient back into the office and discuss it with them. Michael told us how he does it. He sits the patient down and says, here's the problem. And then he observes behavior because people are going to mess up. They're going to not be able to explain that result. And then you can use the result that you have in order to improve that relationship you have. And we hope adherence will improve because the patient knows that you're at least monitoring them. And whatever you do, the result should go in the chart. Even if it is a drug the patient should be on and you're going to continue to prescribe the drug that you're prescribing, you should have a reason for that and not just willy-nilly give the drug to the patient. If you think the patient has started using alcohol again and they shouldn't, but they said they're going to Alcoholics Anonymous, you've corroborated, then you've got a perfectly good reason to give the drug again. And if it's in the chart, you are protected, but you got to write it down. You just can't ignore it. And I want to thank the panel so much for helping with this very difficult discussion today.